So this is just a little bit of a comparison of the two formulations. You have the route of administration, which we've already talked about. The frequency of administration, the oral should be taken daily, and it doesn't really matter whether it's morning or night. Some people feel tired on it. Some people feel like it gives them energy. I don't know why that is and why it varies, but just dose it to fit your patient's needs. So if they feel tired on it, of course, you probably want to give it at night. If they feel like it gives them a little bit of energy, you probably want to do that in the morning. The injectable naltrexone is given every 4 weeks, again, in the gluteal muscle. Dosing range for oral naltrexone clinically will range between 25 and 250 milligrams daily. The FDA approved dose is 50. We have a slide coming up, and I'll show you why I put a little variation on that. And the injectable naltrexone dose is 380 milligrams. It's set, and the manufacturer, it comes in a kit ready to go. So unless you're going to waste some of the medication, which I don't necessarily recommend with this medication, you're going to be administering around 380 milligrams if administered correctly. As I mentioned before, the oral naltrexone is generic. It's only generic at this point. The injectable naltrexone is not. And so if you're an individual without insurance and you're paying cash price, the average price for a 30-day supply of oral naltrexone is about $100. For the injectable 4-week, it's $1,200 every 4 weeks on average. Next slide, please. Luckily, most insurance companies cover the injectable form, including Oklahoma Medicaid. You just have to do some forms and some authorizations generally, but you can get it covered much more readily than it was even 10 years ago. When you look at the dosing specifics for each type, you have the oral naltrexone, again, FDA approved for 50 milligrams daily. It's generally recommended, unless they've taken it before and tolerated it, that you give them a half of that 50 milligram tablet, which is what it's available in, the only availability it has nowadays. And that's just for toleration purposes. So when you give that 25 for 3 to 7 days, because the number one side effects and most prominent side effect and the most common reason for discontinuation is nausea and vomiting with naltrexone. So it's a pretty high incident rate of it. And so we usually try doing a 25 milligrams and then for 3 to 7 days. And at that point, maybe we tell the patient to do it for a week at 7 days. And they're not having any nausea, vomiting, then I would increase it up to 50. If they're still having some discomfort, keep it at the 25 until that discomfort goes away, and then you could look at increasing it to 50 milligrams. It's clinically used in doses up to 150 milligrams, and that is really just titrating up to therapeutic effects. And so if you have someone who's taken 50 and they've been taking it for a couple of weeks, and they're having cravings, or they tell you they can still feel the opioid when they take it, you can increase that dose by 25 to 50 milligrams every 3 to 7 days until you get the response you were hoping for. Once I get to 50, I generally just jump it up by increments of 50. It could, every time you jump up, cause nausea and vomiting, but generally it doesn't. The risk goes down once you've got them on the initial toleration dose. The intramuscular naltrexone comes in a kit. It requires refrigeration and healthcare worker administration. So this is not for your patients to give to themselves. It's a bit of a tricky administration compared to what I'm used to with our newer oral antipsychotic injections, where they all come ready to go. You do have a process that you have to go through, including taking it out of the refrigerator, letting it get to room temperature, which usually takes 20 to 30 minutes. And then you have to reconstitute it. It comes in a vial of solution, and there's a vial of the actual medicine, which is a powder. You have to draw the solution out, put it into the vial powder, shake it vigorously for several minutes, and then pretty quickly give the injection. And that's because it solidifies very quickly. And so they do put extra needles in the kit because they know it solidifies quickly, but if you don't give the injection as quick as possible after shaking it or mixing it, it's going to harden and you're going to waste a needle and a little bit of the medication. And so on this slide, you can see a website that is for that's off Alchemy's website. They have an official video, a training video where you can go and watch the process. I'd encourage you to do that prior to giving your first injection. They will also come and train you in your clinic. So if you have multiple staff, nursing staff, or other staff who help you administer, that you can call the pharmaceutical company and they'll send a nurse educator to demonstrate this. We do this for the fellows every year. We try to, so they can see that for the first time. It is administered in the gluteal muscle, and you'll want to alternate sides each month, which is very typical for injectable administrations. And I'd encourage you guys to utilize their specialty pharmacy system through Alchemies, unless you have a pharmacy of your own in the clinic, because if your patients handle this medication and they don't refrigerate it for any reason, or it gets to room temperature for an extended period of time, the medicine's wasted and it's an expensive medication, and it's difficult to get Medicaid or other insurance companies to pay for 2 injections a month because we didn't follow proper procedure. So you can go again to the Alchemies website, and they have clinics, specialty pharmacies that you can order it from, and they will deliver that directly to your clinic for administration. So you can put it directly in the refrigerator. They do offer samples of extended release naltrexone. It's limited. There's not a patient assistance program that I'm aware of at this point in time, but you can get samples. They'll usually send me somewhere between 3 and 5 samples every month or 2. And so if you have someone, maybe you have you're sending out, they're in a residential treatment facility, or they're getting ready to go into a vulnerable state, you can give them an injection while you wait on that prior authorization process through the insurance companies. Next slide, please. This is from that same Alchemies website where I gave you the note for, and this is just showing the different plasma concentrations of the oral naltrexone versus the intramuscular naltrexone. You can see within the first 3 days of giving the injection, you get a very massive increase in the naltrexone plasma concentration with the injection, which is the blue line, and then it gradually weans off around 30 days. And you can see with the oral naltrexone, what you get are just everyday spikes and quick drops, spikes and quick drops. And so this is just showing you the difference in concentration, and you're going to have a better steady dose of concentration with the injectable versus an oral medication. And this is if they are complying every day with their oral medication. Next slide, please. When you talk about side effects and precautions with naltrexone, the most common side effect, as I mentioned before, is nausea and other GI side effects, including vomiting, followed by headache, dizziness, lightheadedness, weakness. And with the injectable form only, you can also, of course, have pain and inflammation at the injection site. This is actually fairly common in my clinical experience, is that it'll hurt for a couple days, it'll get red for many people, but we'll just have them take some NSAIDs, and generally that'll be better. Do try to alternate sides and not give it on the same exact site you gave it last month, or if all possible. Most side effects of naltrexone are usually transients, and they will resolve on their own. And the best way to deal with most of them is just to delay the increases, like what we talked about with the nausea and vomiting aspect, until they resolve, and then we could look at increasing them if we're using the oral version. If you're using the injectable version, by the pharmaceutical manufacturer says you don't have to start with an oral version. You don't have to trial it. I generally do, just for a handful of days. I don't delay too much, because people are not good at taking the oral version, but I usually do a 3 to 6 day 25 milligram dose of oral naltrexone to see if I'm in an outpatient practice, just to make sure that they tolerate the medication, don't have any significant side effects before I give them a 4-week-long injectable. But that is not required. You don't for use of the medication. It's just something I personally do. If I'm in the hospital, I just give them a couple doses, and if they tolerate, give them an injection when they leave, kind of thing. There is a rare side effect, potentially, of hepatotoxicity, and I say potentially because there's a lot of new information, literature coming out that shows maybe that the initial concerns about the liver failure from the medication itself was well overblown, and it was studied in individuals with alcohol addiction who likely had liver inflammation and problems from the alcohol itself. When we start looking at it with individuals who have opioid use disorder, we don't usually see a massive increase overall in liver enzyme elevation. But they do still recommend caution if your patient has greater than 5 times the normal AST and ALT levels prior to starting the naltrexone. So they do recommend still that you monitor the liver function test at baseline, and then at 1 month, 3 months, and then every 6 months for the duration of the treatment. But they now do say, be cautious about withholding it just because you can't get a lab. So maybe you're in an urgent situation, maybe you're in a residential treatment facility that doesn't have lab services, and you want to start someone on this medication, you can start it on them and then get the labs a few days later. They don't recommend withholding treatment to get a lab in most cases, unless you know your patient has liver disease or has a much higher risk for liver disease, like comorbid alcohol use disorder or hepatitis, viral hepatitis infection. Then you might want to be a little more cautious about starting it without labs. Naltrexone will block opioid action at the mu receptor. And so in our individuals who are taking opioids actively, this means those opioids will likely be displaced or knocked off the receptors, and individuals can go through a phenomenon called precipitated withdrawal, which is intense opioid withdrawal that, instead of slowly coming on over a few hours to a day, will hit them within 20 to 30 minutes. It's really intense. It's really agonizing for patients. It's much more severe in terms of the intensity of the symptoms and much quicker acting. It's probably the closest thing you can think of would be when you give someone Narcan who's had an opioid overdose and they wake up kind of in intense pain and sickness. And if you give naltrexone before someone is cleared their opioid receptors off of their other opioids, you could get a similar experience that you have with naloxone, except it's going to last a lot longer. It's going to go on for 3-ish days versus the 30 minutes to 2 hours that you get with naloxone. Next slide, please. So before you administer naltrexone, you want your patients to be 7 days off of opioids without opioid use. And so some things we should do, we should inquire subjectively or ask the patient, when was the last time you used an opioid and what type of opioid did you use? If you can, perform a drug screen, because most opioids have a detection window of like 2 to 3 days. So if they're positive for an opioid, there's a chance that, and they told you they hadn't used in 2 weeks, maybe they're using something that they didn't know was an opioid, like tramadol, that could also result in precipitated withdrawal. And in circumstances where you're just not sure, you can consider using something called an naloxone challenge test, which is where we dose naloxone to make sure they don't go into withdrawal. And I think the next slide goes through how you do a naloxone challenge test. If they're still within that 7 to 10 days or they're at risk for detoxification, we are going to recommend that you work as a provider to utilize medication to get them off prior to administering or prescribing or administering naltrexone. This is kind of tricky, and it's probably if you look at the study that compared buprenorphine naloxone to extended release naltrexone, the injectable form of it, you'll see that was published in Lancet. Primary author was Dr. Lee, and we talked about it a few weeks ago. But if you look at that article, you'll see that a lot of people struggled with and dropped out of treatment in the first week of trying to get onto naltrexone because they had to use different non-opioid medications for the detoxification process. I say you got to, but I mean, technically you could transition someone from an opioid to a buprenorphine taper, but then you would have to wait 7 to 10 days after that taper. So generally, I just like to not do that and just go try to get through the alpha agonist medications. And unfortunately, it's very difficult to do on an outpatient basis because people are going to have these alpha agonist medications, clonidine and naltrexone specifically, do not resolve cravings. And people, if you look at the studies, they reduce symptoms similarly to buprenorphine and naloxone, with the exception of a few, but patients don't feel that subjectively. They feel much more comfortable on an opioid, rather that be buprenorphine or methadone for detox. But so on an outpatient basis, it's hard to keep your patients from using opioids if you're doing that. But if you can, and they have an inpatient opportunity, maybe a residential treatment facility with a detoxification option attached to that. I know there are some in the state of Oklahoma. 12 and 12 will do that. TRC and the Recovery Center in Oklahoma City, both are state funded detox centers who can help facilitate this for individuals who don't have insurance, who have Medicare and Medicaid. Fortunately, Oklahoma doesn't, Medicare and Medicaid does not cover inpatient substance use treatment in the state of Oklahoma. Not right, but not my decision to make. So those individuals could go to either 12 and 12 in Tulsa or the Recovery Center. And then there are multiple sites across Oklahoma who you could put in just for detox if your patients have insurance. Valley Hope Cushing does a detox only. There's Hillcrest in Henrietta, Hillcrest and Mulgee does that as well. Oakwood Springs can do that. Laureate can do that if they have a bed. So it's another place, Brookhaven in Tulsa. So there's a lot of options if you have commercial insurance, as long as there's beds. And I always say as long as there are beds, because if there's a acute bed deficiency of acute psychiatric bed treatment in Oklahoma as a whole. Next slide, please. So it's hard to find beds, even for people who have just attempted suicide and they end up staying in a medical hospital for a week and getting better before we often get them in a psychiatric hospital. So this is the naloxone challenge test. You can use either intravenous or intramuscular subcutaneous or naloxone. If you're using the intravenous naloxone, you're going to get results quicker. They recommend administering 0.2 milligrams of the intravenous naloxone and then waiting for 30 seconds to see if you get any kind of a reaction or withdrawal. If no withdrawal occurs within 30 seconds, they recommend go ahead and administer an additional 0.6 milligrams of intravenous naloxone and then observing the patient over the next 20 minutes if they have withdrawal. The subcutaneous naloxone, the recommendations are to administer 0.8 milligrams subcutaneously and observe for 20 minutes for an initial withdrawal response. If you don't get that, the recommendation is to re-administer 0.8 milligrams of subcutaneous naloxone in 24 hours and observe for withdrawal. I usually don't do the next 24-hour dose, but that's what the recommendations are, just because we don't always have the opportunity to get our patients back in 24 hours. So sometimes we have to go with the way we're going, go with what we can. And most of us don't have don't utilize IV access in our outpatient clinical situations. So we often have to use the subcutaneous if we're going to do that. Keep in mind that these are not guarantees still for precipitated withdrawal, particularly with fentanyl being the primary opioid. Some people can pass a naloxone challenge and still precipitate when we give them a big dose of an injectable or an oral naltrexone. Next slide, please. So it's not completely fail-proof, but it definitely increases your chances of not precipitating withdrawal if you do a naloxone challenge test. So a couple things about alpha agonists, and they work by blocking activation of the locus coeruleus, and the locus coeruleus is the center in the brain, or the area of the brain that releases norepinephrine. And so one of the things that opioids do is block the release of norepinephrine in the brain at the locus coeruleus. And so I always think of it as when I'm taking an opioid, I'm kind of damming up my norepinephrine, only letting a little bit out, but not letting the full amount. And so when I come off the opioid, that dam breaks open and we get this cascade of, or this significant increase in norepinephrine in our body, or in our brain and throughout our body. Norepinephrine is also called noradrenaline, so it's very close to epinephrine in that it causes general activation of the body. And so people with opioid withdrawal tend to get higher, their blood pressure can go up, their heart rate can go up, they start sweating, they start having nose running, they get very anxious, they have insomnia, a lot of pain throughout their whole body, and they can get nasty GI symptoms, including vomiting and diarrhea. These alpha agonists work to alleviate a lot of those symptoms, at least to some extent. and but they don't alleviate cravings as well. And in my experience, they're not as good at knocking down all the GI symptoms or the pain symptoms. The alpha agonist, particularly clonidine, is decent at helping people sleep and decent at helping anxiety, and good at reducing blood pressure as well as pulse rates and some of the restlessness. But it's got some deficiencies. It's if you have the option, if your patient's not going on to naltrexone, and you have the option of a detox with an opioid, I recommend using buprenorphine or methadone to detox. It makes your patients more comfortable. And we'll talk about detox versus maintenance when we go. I actually encourage maintenance, not just detox with buprenorphine or methadone, but we'll talk about that later. Clonidine is one of the agonists that, while it's not FDA approved, has been used for centuries in the United States, or not centuries, decades in the United States for treatment of opioid use disorder. You can do it, you can treat it, use it symptomatically at 0.1 milligrams, usually orally every 6 hours as symptoms indicate, or you can do what I like to do, and that's a taper, particularly on an outpatient basis. If we just say, hey guys, watch your, just take it when you want it, it can be very, very tricky on whether they actually get the administration. Keep in mind that it's ideal that you monitor blood pressure, because clonidine is used for emergent hypertensive reductions, and it can lower blood pressure as well as heart rate. And one of the biggest caveats or problems with clonidine as a sole agent for opioid detoxification is that you have to hold doses sometimes because of lowering of blood pressure or pulse rates. And so usually, if your blood pressure gets below 100 over 60, I'm usually going to hold the clonidine, and if the heart rate gets under 60, I'm going to hold the clonidine. And they're of course going to be you have to individualize care. So if you got a marathon runner who's probably not using opioids, but sometimes it happens, and their resting heart rates like in the 50s or the 40s, I mean, you have to think that through. Do I want to use clonidine and have that risk? In that circumstance, you're going to need a little more intense monitoring, and can you do that on an outpatient basis? There is a newer medication called lofexidine. It's not a new medication. It's been used in Europe for decades. Newly approved in the United States, specifically for opioid withdrawal. It's also an alpha agonist that does not decrease blood pressure and heart rate nearly as much as clonidine does, and it comes in a pack, a detox pack that is used for 7 days and then tapered over 2 to 4 days. And I'll show you the slide that has the pack number on that. This is a trade name medication only. It's very expensive, into the hundreds of dollars, and so it's difficult to get covered in my experience. And if you don't have blood pressure concerns, it's kind of a waste of social money or systemic medical care money to use lofexidine in many cases. Next slide, please. Here's the clonidine taper I generally use. This is for non-precipitated withdrawal, but gradual withdrawal with short-acting opioids. So this would be a little bit different with methadone or buprenorphine, because they're going to take 2 or 3 more days to start the withdrawal process. But usually what I will do is, if someone's been off their opioid for a few hours, 8 hours to 12 hours, they will start to have withdrawal. Most start to experience symptoms of withdrawal in most cases within 12 to 24 hours. On the first day, the symptoms are not as pronounced, so I do a little bit of a lower dose. I do 0.1 milligrams every 8 hours times 3 doses. And then days 2 and 3 tend to be the most intense, so I increase that dose if their blood pressure will tolerate it to 0.2 milligrams every 8 hours on days 2 and 3, on days 2 and 3. And then on day 4, I go back to that day 1 dose and a little bit smaller, because symptoms start to get a lot better if it's not methadone or buprenorphine that you're detoxing individuals off. And then the last day, on day 5, I decrease the frequency of that 0.1 clonidine to every 12 hours versus every 8 hours. Again, you have to monitor blood pressure, and you may have to hold doses, particularly on days 2s and 3s, because those are decently high doses of clonidine in terms of blood pressure reduction. Next slide, please. Sorry. And this slide just shows you the lofexidine standard It comes in a pack. We just poke the doses up out and take them. It comes in 0.18 milligram tablets. And so days 1 through 7, you're going to take number 3 or point of those 0.18 milligram tablets, which is 0.5 milligrams every 6 hours. And then after day 7, you'll start dropping the dose down. So on day 8, you go to lofexidine, you go to 2 of those 0.18 tablets every 6 hours. And then on day 9, you go to 0.18 or 1 of those tablets every 6 hours. So you just kind of slowly wean them off on days 8 and 9. Next slide, please. And the last thing to remember with alpha agonists is that you often have to use other supplemental medications to help control some of the symptoms that the alpha agonist doesn't do on its own well. And that's one of the biggest positives about buprenorphine and methadone, is that you generally don't have to add extra medications. The medication alone alleviates the vast majority of the withdrawal symptoms, as well as the cravings. And if your goal is to put them on maintenance of either of those, it makes sense not to use the alpha agonists and these other medications to detox them. Because with buprenorphine, you can start it as soon as their withdrawal kicks in and gets to as soon as mild to moderate withdrawal kicks in. Methadone, you can start it even before withdrawal begins. And with naltrexone, unfortunately, again, you have to wait 7 to 10 days. And so there's pros and cons of all the above. Naltrexone might be an option for individuals who can't take an opioid agonist. So if you're in the state of Oklahoma and you are a healthcare provider in the nursing or physician realm, you can't. They don't allow. If you're under supervision by your board, they won't allow you to take methadone or buprenorphine naloxone as part of your treatment. And if you test positive for it, it would be they would use that. They could use that to terminate your license or say you failed the program. And so those physicians and nurses are often limited to things like naltrexone. Pilots are often in the same boat. I don't think that at this point the FDA does not approve any of these medications. If you have a pilot, even before you start naltrexone, you want to talk to them, have them talk to their supervisors about whether they can take that or not. And some people just don't want to be on the opioid. Maybe they've been on buprenorphine before and coming off of it was horrible for them. Same could be said for many people who take methadone and then want to come off of them. Those individuals would be candidates for the naltrexone. But this slide just shows the other medications that we often have to use if we're using clonidine or lofexidine to treat symptoms. And so sometimes the nausea or vomiting doesn't completely resolve. You can use promethazine 25 milligrams every 6 hours, or you can use ondansetron, which is I prefer to use in an outpatient setting because people like to take promethazine, a lot of promethazine to feel good. It's harder you don't get as much euphoric effect with the oral version as you do the intramuscular or rectal versions, but promethazine does work for a lot of people. Ondansetron would be dosed usually between 4 and 8 milligrams every 8 hours as needed for nausea and vomiting. For diarrhea, almost everyone just uses loperamide, or it's over the counter. You take 4 milligrams by mouth at the onset of diarrhea, and then 2 milligrams every 2 hours until the diarrhea goes away, not to exceed a total of 8 milligrams a day. Loperamide can also be misused, but it's over the counter, so anyone's going to have access to it nonetheless. It takes a very high amount of loperamide. You have to take multiple tablets of it to get any kind of systemic absorption. It is basically an opioid substance that stays on the bowel. It stays in the bowel except in very, very high doses. A lot of individuals for pain breakthrough will use some kind of muscle relaxer. I think in Tulsa, a lot of the facilities use methylcarbamol, so trade name Robaxin, about 750 milligrams every 6 hours is needed for muscle aches or muscle cramps. But a lot of people just use an NSAID. So ibuprofen, 400 to 800 milligrams every 6 hours, or naproxen, 500 milligrams every 8 hours, or every 12 hours, sorry, for use of the pain, and those work well. Same thing with sleep medication. I think in Tulsa, Most facilities, the primary go-to is trazodone at 100 to 150 milligrams at bedtime, but other places, some facilities also use things like quetiapine for treatment as well. And the quetiapine is usually used somewhere between 100 to 200 milligrams, 50 to 200 milligrams by mouth for sleep. And that should be the last slide, but I'll have them advance it just to be sure. Okay. Any thoughts, questions, comments before we move to a case?